Hi,
All
Anish. How
right.
are you?
Good. How are you, Michelle?
Fine, thank you. For the audience, I'm Michel Akkad with my co-host Anish Koka. We're going to
Hello.
talk about the ischemia kerfuffle today. You want to take it away,
Yeah, absolutely.
Anish?
So,
Okay.
so it is quite a kerfuffle. So it's given me great joy to watch the angst on Twitter over this. So just to try to get a brief overview of what to lay some context for how this happened. Um, it, this revascularization in folks with stable coronary artery disease, so not people that are having heart attacks, but people that are walking around with significant coronary lesions. And the question is, does revascularize? And this has certainly evolved over time. I guess you would say that the big studies that have kind of guided this in the last, whatever, 5 or 6 years has been the CARDS trial and the BARI 2D trial. And, both of them did not show any difference in hard endpoints when it comes to recurrent heart attacks, recurrent significant cardiac events, with a revascularization strategy versus a medical strategy. The knock on Courage certainly is that most of the patients were relatively low risk by the criteria of how much ischemia they had. So the idea that still has some staying power in most cardiologists is that if you have a lot of ischemia with stress, that these are folks that may benefit from a revascularization strategy over a medication strategy. And so of course, Orbita fired up Twitter by again showing, of course, Orbita was done for symptoms only, and Orbita was is trying to pierce this idea that there's whether or not there's even a symptom benefit to coronary disease, in
PCI.
stable coronary disease.
Right.
Yes, the PCI in stable coronary disease. And now we have an ischemia as a large ongoing trial to follow Courage, the Courage trial and the BARI trial, that says, all right, if we take people with stable coronary disease who have at least moderate ischemia, and so it's a large trial, how are folks going to do in a revascularization versus medical therapy decision, medical therapy arm?
Mm-hmm.
And so that's where we sit with ischemia. Now, ischemia has been ongoing for a while. There are thousands of patients. I forget exactly how many thousand patients there are. And apparently, and I think Venk Murthy, who's a cardiologist out of Michigan, is one of the first people that I saw bringing this up, was that he noticed he got that the endpoints had changed for ischemia. So one of the knocks on some of the prior stable CAD studies was that the endpoints that were shown to be different were soft. So not death or MI, but recurrent hospitalization for revascularization. So ischemia was initially designed apparently with an outcome measure that was just hard endpoints and didn't include readmission to hospitals for revascularization that are guided patient. And that apparently changed, and that caused an explosion and quite a controversy about whether or not this endpoint change was pre-specified or not. Dr. Darrell Francis, the terror of
Medical Twitter,
cardiology,
cardio Twitter.
medical cardiology Twitter, and his group put out essentially an editorial in Circulation Outcomes, suggesting that this was something that was going to really impact what the trial means, because
Right.
in the middle of the trial or towards the end of the trial, you have a change in outcomes. And there were some, and then the initial principal investigators of the ischemia trial then responded, saying that there were some factually incorrect incorrect statements that were made, and essentially what they said was that no, this change in endpoints was pre-specified if the event rates in the two arms was very low. So that, I think, is where
Right.
we stand. That was
Right.
3 minutes too long.
No, it's okay. But just to clarify one by so initially the trial was designed to only have hard endpoints at the end, or to examine hard endpoints. Right. Because soft endpoints, supposedly are soft, meaning they're subject to the bias of the doctors, knowing that the patient has not been revascularized. They may be more tempted to go ahead and put a stent in, and right. so forth. So hard endpoints only, and then they had a hard time recruiting enough patients. So then they switched to adding the soft endpoints to the mix, because the more endpoints you have, the easier it is to draw a conclusion by sort of statistical inference.
Right.
And so so that's caused a lot of outcry. So what do you think?
Well, it's I mean, one point is that the soft endpoint people keep talking about is the endpoint that drove the FAME trials. The FAME trials were trials that looked at FFR, a physiologic pressure wire monitor across a coronary lesion to see if there was a significant pressure drop with stress or not. And the FAME trial folks saw a benefit to FFR guided interventions versus medical only interventions, except again, death MI was no different, but the endpoint that mattered in this case that drove the positive outcome for FFR guided interventions was hospitalizations for chest pain and unstable angina. Now,
right, meaning the people who did not get a stent were more likely to get re-hospitalized, right, 6 months later or a year later or down the line.
Right, exactly.
Right? As opposed to those who did get a stent on the basis.
But the problem is, this is the issue. This is the point. What do you do? I mean, as somebody who is running this trial, if somebody has has chest pain and shows up in the ER, and after they've been medically treated, there's some judgment call that has to be made about whether or not this is an acute coronary syndrome or not. And in 50% of them, in FAME, 50% of them had significant ST changes, or had or were biomarker positive. So if you have a significant coronary lesion,
it was still a nocebo effect. It was the patients. I don't have a stent, and they had so much stress from knowing they didn't have a stent that it caused demand ischemia. Yeah.
This is the problem with blinding. This is the point that the Francis group brings out, is that, how can you trust that? Because everyone knows, the patient knows that they have a significant lesion that's not to be, that can't be, that hasn't been treated. Yeah. And the treating cardiologists know as well. And
yeah, that's right. So the EBM purists hate the placebo effect.
Yes,
they really hate the placebo effect. So they want the patients to be blinded. They want the doctors to be blinded, yes. And they just absolutely hate the placebo effect, which is, it's kind of silly, because when you think about it, placebo is part and parcel of medicine.
Right.
There's no way. I mean, there's no way to prove it, but imagine being treated by a robot. I'm sure people who are treated by robots would have poorer outcomes, even if the robot followed the precisely the same sequence of steps as the human beings.
Right.
So that's one point. I mean, that's this aversion to the placebo effect, which is not it's not just the ischemia trial or these people. I mean, I think in general in medicine, the last 40, 50 years, we've been completely obsessed with squashing the placebo effect. And
and say you do this perfect trial, right. Say you do this perfect trial where everyone is blinded. Like, do we then start practicing in a blinded fashion in real life? Meaning, right. And I went through this with a patient just the other day. So they asked me, I was struggling to get this patient who has a calcium score of 200 or something, and isn't on a statin, and I'm trying to get them to take a statin. And she asks me, what are the side effects of being on a statin? And I told her, I was like, I don't think I should tell you. I mean, because if I tell you, and I went through, exactly. I went through the whole nocebo effect thing and said, look, there's a chance that if I tell you what symptoms you're going to have,
you're going to have them. Yeah, exactly.
And so she wasn't exactly, I mean, we laughed about it and stuff. And
Right.
at the end, she was like, "You're joking, right? What is it?" So I was like, "Okay, fine. I'll tell you."
Yeah.
So, we don't practice in a blinded fashion. Should we then start practicing?
Right. Although on the other hand, maybe there may be good reason not to tell the patient, to blind. I mean, I think it was Lisa Rosenbaum who had an editorial, I don't know, a couple of years ago, about this question of paternalism and, withholding information. It used to be the case that doctors withheld information from patients if they thought that the patient could not really handle it for some reason. And now, of course, it's anathema. If you withhold information, but maybe there is an effect. There is a nocebo effect. I'm perfectly willing to accept that. And so, what's wrong with couching your message in a certain way so as to influence how the patient is going to react? I think that's perfectly normal and humane. But of course, now in the age of EBM, it's what? Are you kidding? And so, and in the age of patient autonomy and all that stuff. So yeah, I mean that's a a difficult problem for the EBM people to deal with. They always have to blind everything, and it makes recruitment more difficult and whatnot. And so then they have to add soft endpoints, and then the soft endpoints, they're. But what's funny also is a frequent comment that I saw is that the anger against the switch from the soft, the 5-component endpoint to the 2-component endpoint. The anger was that, you screwed our chance to have a definitive answer on the value of stents, right, in coronary disease, in stable syndromes. When did a trial ever provide a definitive answer? It's like, you guys, you screwed up. We were going to have a definitive answer, and now you blew it, and it's never going to happen. There's never any definitive answer. I mean, each time you get a trial, it's always like more research is needed, and because it's a trial only talks about average effects on average people that are pre-selected and all that stuff. And there's EBM never gives any definitive answer to anything.
Right. So the great example of what you're saying comes from David Brown. David Brown is his Twitter handle is @DavidLBrownMD. He's from Washington, St. Louis. He wrote the editorial for Orbita the editorial for Orbita in Lancet, the accompanying editorial, and he said, in no uncertain terms that stents are likely a sham. I mean, that was your reading as well of that editorial, right? I'm not making it up. Right, yeah. But in conversations with David Brown, in terms of how he practices, right? He runs a chest pain clinic, does a lot of medical management. If he has somebody who has medically refractory angina, what does David Brown do? The guy who wrote the editorial saying stents are sham and that, the nail in the coffin of stents is here. He says, he sends them off to the cath lab to get stented. Right. I mean, so I don't quite understand. This idea that like there's finality is to be gained by any one of these things.
Right.
So I mean, for you, Michel, like I guess
part of it, I think, and I think there's so ostensibly the claim is that we all get a sense that stents are overused. And I think it's true. Stents are overused.
No question.
And they're overused for a lot of, possibly unpalatable reasons. Maybe there's a profit motive that, doctors want to make more money by putting more stents and so forth. But the idea that we're gonna remedy this with a clinical trial is kind of silly as far as I'm concerned. It's like using the clinical trial not to answer a clinical question, but to the clinical trial as a tool of social change, right? So the stent jockeys were stuffing their pockets with dollars, for decades and continue to do so. First of all, they don't continue. I don't think so. I mean, I think this attempt to change practice with clinical trials, it always comes like 10 years later. As far as I'm concerned, from my observation, the volume of interventions and the profitability of intervention has come way down, and it had been coming down even before the COURAGE trial. when the Courage trial said, aha, we're showing that stents in stable angina are, not as valuable. It was, the usage of stents was already coming down in that setting. People, honest doctors were seeing that from their experience, and they were changing their practices. Dishonest doctors, maybe not, but reimbursement was coming down anyway, so the profitability, the value of doing stents was coming down and so forth. So the volume of stenting was coming down, and the fact that it has continued to come down after Courage doesn't mean that Courage was like, aha, this game changer in clinical practice. I think it's likely that it would have changed no matter what. I mean, maybe it accelerated the change, so forth. But anyway, I mean, I think I find that a little bit unpalatable, because on the one hand, we're claiming to do science for the sake of science, but on the other hand, it seems that a great deal of motivation is to change social practices, because we don't like that other people are making, whatever. So that's one thing. But the main point is that no trial is ever definitive, and it's always subject to judgment. And in fact, the whole EBM idea that trials can do away with judgment is ridiculous, because there's judgment at every single step of running a clinical trial, and there's judgment at every single step of interpreting the results of a clinical trial, no matter how well it is conducted. And
and one of the big reasons for that, as you're pointing out, is that is this idea of equipoise as well, correct? I mean, you have to have a certain amount of equipoise in the, in this case, in the cardiology community, to say, yes, we want to randomize patients who have significant amounts of ischemia to a medical therapy only arm. And there's, for whatever reason, there isn't equipoise to take somebody who has some large amount of ischemia and randomize them to medical therapy only. Some of the upset is that there isn't this equipoise, and it's like, why isn't there this equipoise? So Larry Houston, who writes under the Twitter handle Cardio Brief, he wrote a pretty strong editorial in his blog, saying that, essentially implying that the reason that these endpoints were changed, and the reason that people weren't being enrolled in this trial had related to the fact that the PIs at certain places did not want the results, don't want a definitive result, because so there's some nefarious motives of interventional cardiologists sitting at these various centers, and they're not enrolling patients because they want to see they don't want to see a good result. I really completely, utterly disagree with that. I mean, yes, there are people with nefarious incentives who do things in medicine and in other spheres of life, but I think, it's a hard question. It's like, do we have enough equipoise right now to take people with large amounts of ischemia and randomize them to medical therapy only? I don't know that there is. Do you? Would you randomize somebody into ischemia given what?
No, I don't. Me. I'm sort of I'm an extremist. I'm an extremist. I don't care at all. I don't care about clinical trials at all. And I'll tell you why. I mean, say you have a clinical trial and it shows that there is an effect, that stenting does help. It's never going to show that stenting helps in 100% of the cases. It's always going to be like 60%, 50, 40%, 60% mortality or death or MI or whatnot in the medical arm, and 40% in the stent arm, something like that. I mean, some kind of balance. Well, that doesn't tell you when you have a patient in front of you. You don't know in which percent is going to be. So it doesn't change the equipoise. I mean, the equipoise remains with you no matter what. And if the stent trial shows no effect, same thing. You're dealing with a patient in front of you, and really, it's uncertain what's going to happen. And so you have to use other arguments to make a decision. You can't use the argument about the average treatment effect in a given trial that has certain limitations. That is,
Michel, isn't there some? I'll push you.
Be the devil's advocate, right? You're the devil. Yeah, go ahead.
Don't trials give you a sense of what's happening now? Meaning, Orbita would suggest that Orbita could suggest that that there may be a fair number of folks who are in cath labs for stable CAD that are not getting a huge symptomatic benefit from a stent.
Okay,
Courage would suggest that there's a fair number of patients that are in cath labs with stable CAD that can be medically managed initially.
Yeah, but to me, that's not a surprise. That's not a surprise. I mean, I knew that from the beginning.
Why is that not a surprise to you? Like, how did you come to that?
From experience, I mean, first of all, especially if you're, I used to work as an interventional cardiologist. That was my primary function, which is what it is in our current system. Everybody's super specialized. So the interventional cardiologists are typically not the referring guys, right? So you receive the patient as an interventional cardiologist, and the story is always kind of iffy. I mean, yes, you see a lesion, but this chest pain syndrome is a little bit, not all that convincing, and so forth. And you put the stent, and you really have no idea whether you're doing the patient any benefit or not. And we also know about stent thrombosis, so you always have to take that into account. You have to take into account the fact that you're not. I mean, you know that you're not gonna. That stents don't quote unquote save lives and whatnot. I mean, obviously everybody knew that because we knew about stent thrombosis, and we knew that stent thrombosis is a serious outcome. So it's in the realm of the possibilities that a stent will have no effect, even though there's a lesion there, right? Maybe even a lesion with a positive stress test or whatnot. It's in the realm of the known, okay? But it doesn't change the fact that you still don't know specifically what will happen to the particular patient in front of you, right? So you know that all these things are possible, okay? And whether they're possible 50% of the time or 60%, it doesn't change anything. You make a judgment, and then you have to, for me, and the system, the way it is, but it's a different conversation. We're not going to get into it, but it hinders me in trying to apply my best judgment possible, because there's inherently different, conflicts of interest and biases that the system actually imposes, on me and on my judgment and on the judgment of the patient as well, because the judgment of the patient is important. But that's what I'm saying is that it doesn't, nothing gets clarified by a clinical trial. There's never a great aha moment unless you really adopt the framework of of ABM, which is this notion of equipoise that really we don't know anything until we run the clinical trial. No, it's not that we don't know anything. We know that all these things are possibilities. We don't know exactly how it's going to fall when you run a clinical trial on average, but who cares about the average? I mean, to me, in clinical practice, that really is.
So it doesn't apply to the patient sitting in front of you, but it perhaps for me gives you a snapshot of what's happening to a lot of patients around the country. So
okay, all right, it's right. It's a public health. It's a piece of public health information.
No, but I thought this before Orbita, and I thought this before ischemia too. Like the problem, there's a bias towards the null for all these studies, because the highest risk patients, the ones where you don't have equipoise, don't get randomized by cardiologists. So it goes to your point that unfortunately, this idea that there's any one definitive trial, or any trial that's super definitive, whether it be CAST, which is the favorite of many folks, or whether it be stable CAD, there are no definitive, single definitive things that can for sure tell you what you should be doing for the person sitting in front of you, and which is why biology and my feelings on this from before, but that's why biology and bioplausibility are still incredibly important. Right. And yes, we may be wrong at times, but that's part of how one progresses is by unfortunately running into these dead ends and making mistakes.
Right. Sounds good. Anything else you wanted to add about ischemia? I mean, I don't know. To me, it's much to do about nothing.
Yes.
On both sides. I mean, I'm not holding my breath for the results of ischemia, and I don't really care personally if it had 2-component endpoint or a 5-component endpoint, or but it certainly got a lot of people talking, and And again, as always, it'll be more research needed. And meanwhile, technology changes, practice changes, incentives change, and they change not because of the clinical trial. Incentives change because now doctors are more employed and salaried and whatnot and so forth. Also, people get bored with stents. Stents 15 years ago it was super exciting. Now it's like meh, for the cardiologist to do. And so the practices change. The epidemiology may change as far as that. We have no idea. The behavior of coronary disease. Who knows? We talk about coronary disease if it's a fixed thing, but who knows? We barely understand that beast. And so I think it's going to be, it's going to keep the academics employed for a long, long time. That's for sure.
Yes, that's for sure. We'll merit tons of discussion. There will be no other answers, and then we will need more millions of dollars from the NIH to run the next definitive trial.
That's right. That's right.
We're in a recursive loop. We're not coming out of. Alrighty.
Okay, Anish. Is that it?
Thanks, Michelle. Yep,
okay,
that's
welcome. See you next time.
Yep. See ya.
Bye.
Bye-bye.